Hi everyone. As some of you know, I've had my Twitter account reinstated after a long holiday, 4 years. I've changed my Twitter handle, so I'm no longer Skeptic Out UK. You can now find me at MP McLachlan. Now, puberty blockers. What is known about them is easy enough to find on the web. In this video, I'm including just the information that I think I would want to know before agreeing to put any child of mine on them. Puberty blockers is a colloquial term for gonadotropin-releasing hormone agonists, GnRH. They work by inhibiting estrogen and androgen production, and they are approved for use by the US Food and Drug Administration, the FDA, for a number of conditions, including the palliative treatment of advanced prostate cancer and advanced breast cancer, for managing endometriosis, and for central precocious puberty, which is early puberty, defined as premature sexual maturation. Like all powerful drugs, they have risks and side effects depending on what condition they are used to treat. Here is a comment that appeared below the video I did about Jon Stewart. I have been treated with a GnRH agonist for 6 months for endometriosis. I had severe side effects from the drugs that did not stop after treatment and permanently lowered my quality of life. Throughout treatment, my gynecologist made light of my problems, saying that they weren't caused by the drug. It wasn't until after treatment that the nurse affirmed that such reactions were common. Seeing Jon Stewart's naive trust in the medical establishment was dismaying, to say the least. Of course, as time goes on, newer formulations can be developed, which can bring with them different risks and side effects. This is par for the course with science-based medicine. Used for early puberty, these drugs are said to have a good track record of both safety and efficacy, although there is quite a bit of anecdotal evidence highlighting the potential risks. This story from the United States is 6 years old. At age 21, this woman's jaw joint had deteriorated so badly it had to be replaced. She's been diagnosed with degenerative disc disease and fibromyalgia, which is, of course, a chronic pain condition. Her teeth are shedding enamel and cracking. None of it made sense to her, she said, until she discovered a community of women online who describe similar symptoms and have one thing in common. All had taken a drug called Lupron for early puberty. Lupron is the brand name given to the puberty blockers mostly used in the US. Last year, the FDA added the risk of pseudotumor cerebri to the labelling. That is a horrible condition and potentially serious. It can result in vision loss. Of the 6 cases mentioned in this press release, 5 were being treated for early puberty. The 6th is described as receiving transgender care. Now, that usage for blocking puberty in physically healthy adolescents who are distressed about their sex and who reach puberty at the normal time, which is a usage for which they are not approved by the FDA or any other authority in the world, is what this video is about. I did make a previous video exposing self-described skep chick Rebecca Watson's very dishonest promotion of puberty blockers, in which she repeatedly claimed that puberty blockers are fully reversible, and in which she consistently failed to make clear that the evidence she was citing for puberty blockers was for their use in central precocious puberty and not for normal puberty in adolescents. It seems that not everybody understands why the difference is important. But basically, if puberty blockers are stopped early enough and the child is free to go through a normal puberty with all the physical and mental development that involves, then in theory at least they shouldn't suffer from the same problems as the child whose critical period of development has been shortened, as happens to children who are prescribed puberty blockers at the start of Tanner stage 2. In that earlier video, I pointed out that the NHS had amended the information about puberty blockers on its website, which once said they were considered fully reversible, but no longer does so. The reason for that rather important amendment was a review of the evidence then available, which found that the evidence of clinical effectiveness and safety of puberty blockers was of, quotes, very low quality. NICE is the National Institute of Health and Care Excellence, by the way. And even before that, a literature review carried out in Sweden found an extreme paucity of evidence for all aspects of treatment for gender dysphoria. A statement from the Karolinska Hospital said, "These treatments are potentially fraught with extensive and irreversible adverse consequences such as cardiovascular disease, osteoporosis, infertility, increased cancer risk, and thrombosis. This makes it challenging to assess the risk/benefit for the individual patient, and even more challenging for the minors or their guardians to be in a position of an informed stance regarding these treatments." Now, I did not make any specific claims for puberty blockers in my video response to Rebecca Watson. What I argued can be summed up in one sentence. You cannot, in all honesty, say that the blockers are fully reversible if their long-term effects are still unknown. I surely don't need to explain why it's unethical to make claims about powerful drugs that are not supported by scientific evidence, and it is even more unethical to misrepresent the contents of papers as supporting your claims, which is what Rebecca does. Let me just remind you of the evidence pyramid. Third from the top are the randomized controlled trials, RCTs. To produce the most reliable results, clinical trials must be sufficiently large, they must have enough participants, they should have a control group, meaning participants who are given either a placebo or a comparative treatment to the treatment that's being tested. They must be randomized, meaning that who gets the treatment being tested and who gets the alternative, whether or not it's placebo, are randomly selected, not individually chosen by clinicians. And they should be double-blinded, meaning that neither the participant nor the medical staff know which treatment or placebo they are getting. Above the RCTs are the systematic reviews of existing studies for the purpose of answering a specific question. If, for example, they wanted to see if a drug used to treat a chronic cough commonly caused headaches, they would review all the studies conducted on patients taking that particular medication and see how often it's been recorded as a side effect. At the very top are the meta-analyses which combine the results of the reviews and analyze them statistically. Now, obviously with some treatments, as with puberty blockers, you can't have a placebo-controlled group because it would be pretty obvious very soon who was on it. So you have to use different methods of collecting data, like cohort studies, which involve observing a specific group over a period of time, and individual case studies. It beggars belief how remiss the providers of these treatments have been in recording the kind of data that is needed to determine how safe these treatments are. We often hear them described as experimental treatments and using kids as guinea pigs, but it's worse than that, because in experiments you set out the objective and you record your data. That hasn't been happening, or not to any appreciable extent. Quote from an interesting article in the New York Times, I'll link to it below. Many doctors point out that it's not unusual for research to lag behind the launch of new treatments and for drugs to be used off-label on patients without FDA approval, especially in pediatric medicine. An FDA spokeswoman said in a statement that the doctors have the discretion to do so, but also noted that just because a drug has been approved for one class of patients doesn't mean it's safe for another. That should be bleeding obvious. Anyone who thinks it is okay to go ahead with these treatments because of a lack of evidence of harms is either a charlatan or an idiot or both. Right. We all know what happens during puberty, so I'll just highlight a few things that are significant for the purpose of this video. One of them, and sorry for stating the obvious, is that both sexes become fertile. Children whose puberty is blocked at Tanner stage 2 and then go straight on to cross-sex hormones are unlikely to be fertile. Another of them is genital development in boys. We know that if you block puberty, the penis and testes do not grow as they are supposed to. So if a boy who has been on blockers wants to proceed to having a surgeon craft what is referred to as a neo-vagina by inverting penile skin, and there's not enough skin in the genital area to use in this process, it is taken from elsewhere on the body. This is not a straightforward operation. It is fraught with difficulties, and that's all I'm saying, because it's not an aspect that I can bear to talk about. Here's a screen cap of a tweet by Jazz Jennings. He says his mother, sister, and even his surgeon didn't want him to see what his genital area looked like post-surgery because it was so bad, and when he did sneak a look, all he could do was laugh. I suppose that's why he posts 2 sobbing emojis. Poor kid. Another thing that happens during puberty is brain development. That puberty blockers may have a long-term negative effect on the brain has been raised as a concern by many doctors, notably including retired pediatrician Hilary Cass, who is leading an independent review of medical treatments for adolescents presenting as transgender in this country. She writes, "A further concern is that adolescent sex hormone surges may trigger the opening of a critical period for experience-dependent rewiring of neural circuits underlying executive function, i.e. maturation of the part of the brain concerned with planning, decision-making and judgments. If this is the case, brain maturation may be temporarily or permanently disrupted by puberty blockers, which could have significant impact on the ability to make complex, risk-laden decisions, as well as possible longer-term neuropsychological consequences. To date, there has been very limited research on the short, medium or longer-term impact of puberty blockers on neurocognitive development. So, incredibly, even though they continue to be prescribed to thousands of children in many different countries, their impact on brain function during this critical stage of brain development is largely unknown. The best data we have at the moment comes from experiments carried out at Glasgow University on sheep. And I mean animals, not members of the Scottish Parliament. Another thing that puberty kicks off is the development of bone mineral density. Skeletal mass typically doubles during adolescence. I'll say more about that in a minute. But first, what is the purpose of prescribing puberty blockers to adolescents who are diagnosed with the condition that is currently most usually called gender dysphoria. The phrase we hear time and time again is that it's like pressing a pause button and allowing the young person the opportunity to explore their gender identity and time to consider if they wish to pursue gender-affirming treatments, while development of unwanted secondary sex characteristics is suppressed in order to reduce distress. To those whose mindset is already captured, this undoubtedly sounds perfectly reasonable. I could say quite a bit about the nonsense that is gender identity and what it means to explore it, but that would make a very long video, so I'll talk about it another time. Just now, I'll confine myself to saying that it isn't reasonable because it is based on an ideological notion, and it could lead to that young person becoming a lifelong medical patient quite unnecessarily, because the weight of available evidence shows that most children and adolescents who are distressed about their sex but who are not treated with medication do start to feel better as time goes on, and they become reconciled to their sex before reaching adulthood. Evidence also shows that almost 100% of kids put on blockers go straight onto cross-sex hormones, which undermines the claim that all you're doing when you prescribe them to kids is pressing the pause button. No, you're not. You are setting them on a path towards medical transitioning, which means, among other things, that they will probably be infertile, and that, of course, raises the ethical question of whether a teenager can possibly know for sure that they will be okay with being infertile 10 or 20 years in their future. I want to just pay lip service to the speculation that the reason hardly any teenagers desist after being on puberty blockers is because they were so carefully counselled prior to going on them, and only those diagnosed as being truly dysphoric and most unlikely to desist were selected for prescription. That would be a plausible idea were it not for the fact that the clinical presentation of children with gender distress can be highly variable, and there are no studies to show whether there are clear predictors about who will desist and who will persist. And there are, of course, some case studies that give the lie to it. A few years ago, for example, the Times covered in some detail a case study of a girl whom they called Jacob, who at the time had just turned 16 at the time the article was written, and who had been on blockers for 4 years. And she said that it was the worst decision she'd ever made, but it had been sold to her as a miracle cure, and after only a few consultations at the Tavistock Clinic, Jacob was referred to the nearby endocrinology unit, which, she said, did not consider her background, which included the trauma of a sexual assault while she was at primary school and her parents' difficult divorce. She said, "They promise you that your breast will disappear, that your voice will be deeper, that I would look and sound more like a boy. For me, that was the best thing that could have happened." And this brings us to another problem with puberty blockers on adolescents, which is called the psychosocial impact, and which refers to how a young person being suspended in a state of childhood hinders the individual's development of a free personality, sexuality, and identity. So they become disconnected from the typical experiences of their age group and even more isolated from their peers. As with every other hypothesized effect of puberty blockers, there has been insufficient exploration of this aspect. Jacob said that far from becoming one of the lads, as she'd hoped, she felt even more alienated from them as their physiques changed and hers remained the same. They were maturing into adults, she wasn't, and for someone who's trying to fit in as a boy, that's not what you want. She had been the tallest in her friendship group, now she was the shortest, and when her younger brother overtook her in height and strength, she found it too upsetting to be in the same room as him. Could this be a reason why most of these kids prescribed puberty blockers are so keen to go on to cross-sex hormones, so that they can get out of their state of frozen childhood and catch up with their peers? Jacob is one of the rare desisters, not because her gender dysphoria got any less, and not just because of the feelings caused by her lack of physical development. In addition, there were side effects she hadn't been warned about. These included insomnia, fatigue, depression, rapid weight gain, and what may well turn out to be a major issue with puberty blockers, a reduction in bone density, which caused her to break 4 bones on different occasions. A teenage girl's toe shouldn't break when she stubs it. Her wrist shouldn't break when she falls over. These and more happened to Jacob. As I showed in the video I did reacting to Rebecca Watson, bone density is supposed to rise significantly during puberty, but scans on kids on blockers shows that at best it flatlines. This is one of the lies that I'm most angry with Rebecca about. On her website, she has what is supposed to be a transcript of her video, but it's not in fact an exact transcript. One of the things she says that did not make the final cut of her video is, even if trans kids did experience a loss of density, that's something they and their doctor could watch for and control, either by switching to a different puberty blocker or by taking medications to increase bone growth. In other words, even if it does happen in rare cases, it's simply not a big deal. Where is the evidence for the claims that A, if it happens at all, it only happens rarely, and B, it will be alleviated by a different puberty blocker? Why? While there are differences between different blockers, they all work by blocking the sex hormones needed to develop bone density at the crucial time, so why should one be any better than another? And see that it will be alleviated by taking medications to increase bone growth. Where is the evidence for these claims? She doesn't provide any. She doesn't even quote any clinician making these claims. And osteoporosis is a big deal. It's a big deal at my age. In case anyone wonders why I am heavily tattooed, here's a photo of what one of my body parts looked like prior to getting tattooed. It's my right shoulder, in case you can't figure it out. I did not care to be reminded every time I looked in the bathroom mirror of the traumatic accident that left me with multiple fractures because of osteoporosis. The pain fluctuates but never goes away, and I hate getting into bed every night because of it. But I'm old. The idea of a young person on the threshold of adulthood existing in this world of pain, it doesn't bear thinking about. And yet, it took a number of children being injured and hurt in other ways before the Swedes finally banned puberty blockers and also cross-sex hormones for children under 18, except when the child is recruited into a clinical trial with all the careful monitoring and data recording that entails. The case study they publicised in defence of their decision involved a girl they call Leo, who was put on puberty blockers at age 11. At first, according to her mother, she felt better, but before long she felt worse than ever before, and she attempted suicide several times. I did look, by the way, for studies on the effect that actually taking puberty blockers has on the mental health of those kids they are prescribed for. All I could find is a report in the British Medical Journal of a small study carried out by the Tavistock over 4 years saying puberty blockers used to treat children aged 12 to 15 who have severe and persistent gender dysphoria had no significant effect on their psychological function, thoughts of self-harm or body image. a study has found. However, as expected, the children experienced reduced growth in height and bone strength by the time they finished their treatment at age 16. So perhaps not too surprising that Leo's mental health didn't improve. She also started to complain about pain in her back, but it was over 4 years before she got an X-ray which confirmed that she had osteoporosis and she had a compression fracture in her spine. Her medical records say that she has permanent back pain and describes her as disabled as a result of the puberty blockers. Her height is also stunted. It transpires that Leo was not the only child to have been harmed, and reportedly doctors knew about these cases for some time but carried on prescribing anyway. Same situation is happening in the US. See the New York Times article below. I said earlier that anyone who thinks it's okay to go ahead with these treatments because of the paucity of evidence of harms is an idiot, and that also goes for anyone who thinks that just because doctors prescribe them or health organisations recommend them, they must be safe and effective. That is incredibly naive. And that's all I've got to say on this subject now. I hope it's clear that there simply isn't enough evidence to claim that puberty blockers are completely safe and fully reversible. Some of those who take them do suffer adverse physical consequences. We just don't know how many and to what extent, and there is some evidence to indicate that they don't help kids feel better mentally either. Sources are in the description. Thanks for watching. Bye.